Welcome to the Fracture Prevention Central webinar, ICD-10 Coding for Osteoporosis and Post-Fracture Care. Fracture Prevention Central, brought to you by the National Bone Health Alliance, is made possible through support from Amgen, Inc. and Eli Lilly and Company. To ask a question via the webinar at any time, select the chat pod located in the lower left corner of your screen, then type and send your question. I'll now introduce you to Debbie Zeldow, MBA, Senior Director, Clinical Programs for the National Bone Health Alliance. Debbie?
Thank you, and thank you all for joining us today. Today's webinar is one of many of NBHA's activities to improve overall health and quality of life by enhancing bone health. With a collective reach of over 100,000 healthcare professionals and 10 million consumers, NBHA provides a platform to weigh in on subjects important to bone health. With our members, that include 50 organizational participants and 5 government liaisons, NBHA programs really look to meet our 2020 vision of reducing bone breaks 20% by the year 2020. Fracture Prevention Central is NBHA's FLS Resource Center with hundreds of tools and resources all available for your use without charge. There's brochures, business plans, you name it, up on the website, and you can download them and use them to best fit your program. The Fracture Prevention Central webinars, 13 and growing, are available on the Fracture Prevention Central website and on NBHA's YouTube channel, on demand and available for download. Our newest FLS resource is the FLS One-on-One Consult Service, where you have a 1-hour consult with one of our FLS experts. It's easy to access this free service. You just go on nbha.org and fill out the form. Now it's my great pleasure to introduce Ann Lake. Ann?
Well, hello, everybody. We're so glad you're on today, and this is an exciting electric topic and to have over lunch, so I hope you're eating something and you're relaxed. We have a wonderful presenter that I have the honor of working with. We have Ms. Leslie Stovall. She has over 15 years of experience in coding. You can see from her bio, I mean, she comes with a wealth of knowledge, especially in the area of orthopedics, but she also has a lot of contacts with family practice and general medicine practices to help with certain coding issues. She's been very, very instrumental in helping me understand the crosswalk mechanism of ICD-9 over to ICD-10 coding and how that looks particularly in the FLS setting or the fracture liaison setting. So I'm just so excited to have Leslie on today, and I'm going to turn it over to her. We're going to take our time and sort of digest through some of these slides. We want you to feel comfortable with sending your questions on into the Q&A section, and we may address some of those questions as we're going along in the webinar today, as it's appropriate to whatever slide that Leslie may be discussing. I also may interject at times, particularly from a clinical viewpoint of what we might see in the FLS setting and how to sort of bring all this together. So it is a great pleasure and honor that I'm going to turn it over to Ms. Stovall and to begin the seminar today. Leslie?
Thank you, Ann, and thanks, Debbie. I appreciate the opportunity today to speak about this subject. Thank you, everyone out there, for joining us as well. Just to give you a little idea about what we'll be discussing today, we have some good information on ICD-10 and osteoporosis coding. We have a little information on HCC coding, some clinical documentation tips, and, of course, information on the FLS program. We'll try to get to as many questions as we can at the end or throughout the presentation, so just keep those questions coming. So I know everybody, we've all done our ICD-10 training and research, and ICD-10 is here. And it wasn't really that bad, not here with my group, and from what I've heard, it hasn't been too bad all around. I do have some information here about the musculoskeletal system relating to ICD-10 coding. CMS states that 50% of all ICD-10 codes are related to the musculoskeletal system. So that's half. I mean, that's a lot. 25% of all ICD-10 codes are related to fractures. They're so much more specific now. We've all seen that. I don't know if everybody's dealt with fracture coding, but now the site, laterality, and the type of fracture are all included in the diagnosis code. So Chapter 19 has definitely exploded, as well as Chapter 13, the musculoskeletal system. And I did want to also mention we're going to make some crosswalks available for upper ortho and lower ortho, 50 of the most common codes for each. We're going to make those available through the Fracture Prevention Central website. So hopefully that would be a help as well.
And I do want to mention here, this is a great point to say that in the Fracture Liaison Service, whether you're in an orthopedic practice and you're dealing with that post-fracture patient in the global period, or whether you're in a specialty practice like endocrinology, rheumatology, even some of the other physical medicine and rehab, some of the other groups that have taken on the FLS mindset, if you think about it, we're not necessarily focused on that 25% fracture code anyway, not even in orthopedics or in the other specialties when we're dealing with our Fracture Liaison Service. So you don't necessarily have to be so stressed about getting that site laterality and the type of fracture, particularly for the FLS, but what you're mostly going to be interested in is what are those other 50% ICD-10 codes that are related to the musculoskeletal system, and even some of the family practice codes or internal medicine codes that are related to medical conditions that would put the patient at risk for future fractures. So the good thing is that most of these 50% codes and the crosswalk codes that Ms. Stovall has made available will be codes that we commonly see in family practice, such as hypothyroidism or hypogonadism or IBS or celiac disease, diabetes, the common things that we would see that would put a patient at risk for future fracture. So the great thing is when she pulls this together with the HCC or the hierarchical coding, you will see that the common codes that you've already been using are going to be pretty basic for you. So just remember, we're using most of that 50% code is what she's talking about now.
Right. Thanks, Ann.
Mm-hmm.
Next, I've got some information on seventh character extensions and how they relate to pathological fracture coding. There are a few more seventh character extensions when you're talking about a traumatic fracture, but since this is geared more towards osteoporosis and pathological fractures, I wanted to take a look at definitely the three most common seventh character extensions that we're using now in ICD-10. And these extensions are used as the seventh character for any fracture diagnosis code, any injury codes, even injuries that aren't fractures. So we see these with pathological fractures. The three most common are A, D, and S. A is initial encounter for treatment. So you're going to want to think active treatment, surgery, that initial casting, the first visit with the provider for that problem. It's active treatment. D is subsequent encounter for fracture with routine healing. So this is going to be your follow-up visits for that fracture care, any suture removal, physical therapy after injuries, anything that's happening after that active treatment phase. And S for sequela, which was previously known as late effect. So this is a residual effect or late effect, now known as sequela. There's no time limit on when a sequela code can be used, and generally two codes are required, one describing the nature of the sequela and the second code for the sequela. A good example is a scar condition and fibrosis of skin after a burn. So your first diagnosis code would be that scar condition, the fibrosis of skin, and it's a residual effect of that, say, third-degree burn. So you would use your third-degree burn, say left elbow, wherever the site is, and then you would use S as your your 7th character extension.
And I think interject here as far as the fracture liaison service, the time that you probably would not ever use necessarily an initial encounter for treatment related to fracture in the FLS service, but what you might use is the actual subsequent encounter for fracture with routine healing, because if you are seeing the patient maybe 6 to 8 weeks post-operatively or even 12 weeks post-operatively, and they're coming in and they're there and they've already seen the orthopedist, and you look at the orthopedist note that says they had this pathological fragility fracture, but you're interested to know in terms of, can I start treatment or should they be on treatment now based on where they're healing? You might actually use that that code that has that subsequent encounter for fracture with routine healing, just to identify the fact that you've reviewed that information and that the patient is healing from their fracture normally. You're not going to be using this to say that you're treating the fracture in your FLS service, but that's just another identifier to say where the patient is in the process of their healing. As far as the sequela goes, you may use that if you have a patient that presents to you that has been non-weight bearing, and they've been non-weight bearing, and so you may have disused osteoporosis, so you're evaluating them. But guess what? They've developed some kind of RSD or chronic pain issue related to their area of trauma. So you may, at that point, you may use the word sequela because that's in their history, but it's not necessarily just because you use that does not mean that you're treating that part. Is that not right, Leslie?
Right. You're treating the residual effect, and you're just trying to connect those pieces to what caused that problem. That's a great example.
Yeah. Yeah.
We've got some other 7th character extensions here for pathological fractures. For delayed healing, non-union, and malunion. And those, it's pretty clear when to use those as your 7th character extension.
Mm-hmm.
So next we've got some osteoporosis with and without pathological fracture codes. Just to get a look at these. I don't know how involved everyone is with the coding piece or the documentation piece, so I just wanted to include a little bit of everything. The first bullet here is osteoporosis without current pathological fracture. And essentially you're choosing from one of these 3 codes depending on how it relates to your patient. And the age-related or senile osteoporosis without current pathological fracture, localized osteoporosis, or other osteoporosis without current pathological fracture. Your osteopenia codes have kind of exploded as well. They've become, several different codes because they're now specified by site of osteopenia or other disorder of bone density and structure. So the example I have here is other specified disorders of bone density and structure, left lower legs. The same goes with the age-related osteoporosis with current pathological fracture and other osteoporosis with current pathological fracture. Both of these are now broken down into the site of the pathological fracture, and they're talking about current pathological fractures, not something that's back in the patient's history. This is something that they are currently dealing with. And these codes, the last 2 bullets here, both require the 7th digit character for the encounter for that fracture. So again, some examples: age-related osteoporosis with current pathological fracture, right shoulder, initial encounter for fracture. So the osteoporosis codes have gotten a lot more extended, but it's good because we can be more specific.
So one of the things that I want to mention here related to the crosswalk codes, because what I commonly get questions about is, what about codes that we used to use when we were doing screenings? Say a patient was seen and maybe they had a history of a fracture in the past and they were referred to the fracture liaison service because they are at high risk for another fracture. Maybe they've been on treatment or whatever, what have you, and they come to you and you're saying, okay, they got to me, they don't have a fracture now, there's nothing current going on, and do I use Encounter for screening for osteoporosis, or do I use other osteoporosis because I'm looking for the reason that they may have some bone loss? Well, there is a new code that you can use, and it's called Encounter for Screening for Osteoporosis. That is a code that you can actually use if you have, say you have a younger patient that's had a sort of a traumatic fracture, and you're doing a workup on them because they have risk factors for broken bones in the future, but you don't really have a definition of an osteoporotic fracture because it wasn't a fragility fracture, so that you don't have that to support it. What are you going to use to code that? And so you can use Encounter for Screening, which is acceptable, but when you go to order the bone density, this is what I have discovered. When you go to order the bone density, even though the Encounter for Screening code, the new Encounter for Screening code through ICD-10 can be used for that office visit, you still can't use it to order the bone density. So what you end up having to do is you would put in you would probably use the code Other Specified Disorders of Bone Density and Structure, and that's the code that you would use to order your bone density. So even though your office visit may say Encounter for Screening with an ICD-10, you would need that additional ICD-10 code to be able to order your bone density test for that patient, because it won't be connected to the Encounter for Screening. That's what Leslie and I discovered a couple of weeks ago, right, Leslie?
Right, and actually, this is going to take us right into our next slide, because I've got some news about that.
Okay.
That Encounter for Screening for Osteoporosis, it's Z13.820. That's your ICD-10 code, and it was just added per the CPIL, the Claims Payment Issue Log that CMS updates and it keeps together for us. It was just added to the LCD for bone mass measurement, and that's a local coverage determination for Medicare. It was just added on November the 12th. So as of
excellent.
And it's going to be effective back to October. So if you haven't corrected your denials for that specific issue yet, if you're trying to use that Encounter for Screening for Osteoporosis code, that's what the second bullet is about here. They're saying a lot of claims regarding the bone mass measurement codes have denied an error, and Medicare is going back and they are reprocessing these claims. There's no provider action necessary. So those should get taken care of. Now, for your other payers, I don't know how many people we have listening that would deal with this or not, but you might want to send back in claims or call on those claims to get that adjusted, because the change was not made until last week. So that's the second bullet here, and it should get everything cleared up. And the first piece I had, and I've got the links here for anybody that needs additional information. Some of the osteopenia codes, or the Other Specified Disorders of Bone Density and Structure, those codes were inadvertently omitted from the local coverage determination for bone mass measurement as well. So even if you've been trying to use some of those, osteopenia codes, they may have been denied as well. But like this says here, Medicare at least will be reprocessing those claims. And that's the latest update. You can keep checking their website. And again, they put all this information on the Claims Payment Issue Log, CPIL. And if you just type that in once you get to the CMS site or the Palmetto site, you can keep updated on that. So that was our news.
Excellent. Thank you for the update.
Sure. Next thing.
Oh, they're asking you to repeat the code number, if you don't mind.
Sure. It's Z13.820, and that's Encounter for Screening for Osteoporosis. And that would be ideal to use when you don't know if the patient has osteoporosis, and that's exactly what you're doing, is the screening. Okay. So next we've got some information on hierarchical condition categories. This is a risk adjustment model implemented by CMS that is currently used for Medicare Advantage plans only. So this is not original Medicare. This is only the Medicare Advantage plans, like your Blue Medicare, Aetna Medicare, United Healthcare Medicare Complete.
And I'm going to tell you guys, I don't know what Medicare my patients have, so I go ahead and put the HCC codes on all of my patients, so because I don't have time to go back and look and see, but that way it's there if I need it. It also shows what their risk may be, but it's there for documentation purposes, and we know that everybody has to sign up for new Advantage plans and all that stuff December 7th, so, rolling around, it's just best if you kind of get used to putting them on there, because I think it's probably going to end up being a trend down the road anyway. It had been piloted, but if you'll just use this, and if you don't mind, Leslie, just kind of if you can give just like a brief definition of what the HCC actually means. Tell us what that means.
Sure. The HCC is, CMS has come up with codes that assign risk to patients. So the most critical, the more chronic conditions, there are actually some acute conditions included in this list as well. There are over 10,000 HCC codes in ICD-10 with osteoporosis with and without current pathological fractures being part of this. So as long as you're documenting these codes, when the patient has these diagnoses and you're documenting these codes, that will identify that patient once per year to the Medicare Advantage plan, and that will in turn, they send this information to CMS and it affects reimbursement for the next year. So I've got some examples of documentation, even when you're seeing the patient for an orthopedic problem or an osteoporosis screening, if you do monitor, evaluate, address, or treat other conditions, you can code these conditions as well. And that's identifying that patient to the Medicare Advantage plan. So if we're doing this at the encounter when the patient's seen, you can make sure to get that information to the Medicare Advantage plan via the diagnosis codes. So I've got examples here of how you could, state things are stable, or I have evaluated this certain diagnosis, or, addressed it. And basically, it's the same thing that we're doing with our diagnosis codes that the patient is coming in for. We're going to document what we've done to treat the patient. We're going to document how we've addressed it, how we've evaluated it, how we've monitored it. One or more of those. So it's the same thing that we would do for any diagnosis code.
And so in the fracture liaison service, what you're doing is you're seeing the patient for osteoporosis, and you've asked the patient some questions, and maybe you've discovered that in their medical history they have rheumatoid arthritis. So you're going to say to them, are you still taking the systemic steroids, because we have to do a medication reconciliation, right? That's part of meaningful use. So you're looking at that and you're seeing what they're on. So what you would do is you're asking them, are they doing it? You're not prescribing it, you're not doing anything else, but you are addressing it. And so you can put it next to the patient's diagnosis of either, postmenopausal osteoporosis or idiopathic or senile or whatever. Next to that, you can put long-term systemic steroid use for RA, and there is a code for that. I think it's a Z code now. And you would put that next to it with a little parentheses, HCC. You would also mention if they're diabetic or whatever, if they have COPD. So, all of these things you can put on there. And what it does is it basically justifies that the patient needed this screening because they are at high risk for future fracture. So your documentation reflects that the patient has had a fragility fracture. They have multiple risk factors for fracture, so they've been appropriately identified and referred. And then in your assessment, you're putting what are those other risk factors, and that's how you're identifying that patient. So that's another way to guarantee that visit is medically necessary, because everything we do has to be medically necessary. And so if you have those codes there, you're proving that medical necessity. I think there is one question about the codes, and if you, I don't know, Leslie, if you have anybody that can address this. I know you're not on the inpatient side, but someone is asking, do these codes impact reimbursement for inpatient hospitalization if the patient has a surgery? I don't know if that's something that you could address, or would you like to get back with that person about maybe answering that one?
I can try to get back with them and give them some additional information, because this won't impact reimbursement for this visit today. It's going to affect reimbursement for the coming years. We're just identifying the patients. And I did want to clarify one thing. You don't have to, I know Ann has got she's got it under wraps how she does her documentation, and it's perfect. So, but you don't have to put the letters HCC on a claim form or anywhere. You know, the diagnosis code will speak for itself. Also, I wanted to give that code that Ann mentioned. The long-term current systemic steroid use is Z79.52, and it's broken out into two codes. That code, and also long-term current use of inhaled steroids, which is Z79.51. I know I've seen some people asking at other points along the way with the HCC codes, where do we put this on our claim form? There's no place for it. It's their actual diagnosis codes. All the diagnosis codes are in the ICD-10 book, as were they in the I-9 book. So if you want to check the list out, I can also get a link to that out as well, a link to the HCC code list per CMS. And let's see. Next, we've got, I put some clinical documentation tips in here because a lot of these items, these problems, we might not be used to documenting. And with HCC and with ICD-10, everything being so much more specific, I thought this would be helpful. So we can go through these quickly. And I wanted to also mention that, yes, I will make this slideshow available. And we can do that after the presentation today. So when documenting asthma, a couple of things that you definitely want to include are the cause and the severity. So is it exercise-induced, cough variant, related to smoking? Is it mild persistent, moderate persistent? And you also want to include any other factors, any temporal factors. Is it acute, chronic, intermittent? And the code examples here will show how that kind of plays into the ICD-10 codes. They're so much more specific now, and the cause and severity are really going to come into play. With hypertension, and I'm just going to kind of run through these since you'll have a copy of this. The hypertension, you want to include the type. Is it essential or secondary or other? You want to include what the causal relationship is, if there is one. And the code examples listed here kind of show that as well. Essential hypertension, renovascular hypertension. So that's going to really affect your code selection. The next piece is documenting diabetes. And, of course, we want to specify the type 1, type 2, drug or chemical induced, what is that type? Are there any complications? And foot ulcer is a pretty common condition. as an example, and you want to document any treatment. Is the patient on insulin, and go from there. And the code examples again just show how all this information is really just built into the codes now.
So let me make a point here about the FLS particular program, that patient that you're seeing. So when you want to use, we'll just talk about diabetes. So when you want to use the diabetes code, if you have a pop-down screen like we do, we have Epic, so we put in a code. We say diabetes, and there pops down about, good Lord, about 30 to 40 new codes, and everything says with neuropathy, without neuropathy, with renal vascular problems, with visual issues, and if you keep looking at it, there'll be one that says diabetes unknown, diabetes with uncomplications, or diabetes with complications. But you can find one if you're not really sure exactly, because you're not the one treating it and you don't really know. You can find the one that you feel is the most specific and use that one, because you're still identifying the diabetes. You're not treating it. If there's nothing more specific, one of the things that I'm finding right now as we've made this transition is that other people, we still have the ICD-10 codes are listed in the patient's past medical history. So if you try to attach that to their current diagnosis for that visit, it'll say replace this code. And when you click on it and you replace it, there may not be a code to replace it, or there may be 12 are different codes. One of the ones I'm thinking about is reflux. So if I have a patient that's on a PPI and I'm going to pull up GERD, now it doesn't just pull up GERD, it pulls up with esophagitis, without esophagitis, reflux unspecified. So if I don't know, I'm just going to use the basic code, because I don't know if they have esophagitis or not. But my code is going to be probably a little more unspecified, particularly for that diagnosis, not for the osteoporosis part, but just for that diagnosis, because I'm just needing to get that, as part of their diagnostic list. So look at when your drop-down box comes up, look at it, and if it's not all specified, use the one that's the closest to one to get that code on there for you, to show that patient has that diagnosis. If you don't know it's type 1 or type 2, if you don't know, you might just, and they don't have any diabetic neuropathy problems, and their sugars are pretty well controlled, it's probably diabetes with no complications, but you just want to get that diagnosis on there. Do you have any other tips about that if they don't have, because a lot of times you're not going to have all that information in one visit, and the patient can't tell you, was it type 2 or was it type 1? They don't know if their diabetes is mild or moderate or controlled. Leslie, can you help us a little bit with that when we're trying to get those diagnoses on our sheets for our FLS patients?
Sure. So and I know that some providers are not in, there's no reason to know the coding behind this, or at least the more specific coding criteria. But when you are talking diabetes, type 1 or type 2, if it's unknown, I believe we're still, and I'm looking at that right now, I believe we're still coding to, if it is unknown, then you would code to type 2 diabetes, and I did just verify that. Okay. So if you don't have any of the other information, that's why those unspecified codes are still there. And there are circumstances where you have to use an unspecified code, and that's why, they are still there. If you don't have all that information for this or that, for diabetes, it's going to code to type 2, but otherwise, that unspecified code is what you're going to want to use.
Correct.
Yeah, and unfortunately, there are times when we just don't have all the information, especially if that's not the reason for the encounter. And that's what you want to focus on, of course, is the reason for the encounter. I hope that helps.
I think it does, yeah, because your main codes for your FLS, you really want to be as specific as you can related to the osteoporosis part. The other stuff is just for medical necessity and showing the patient's risk of compromised bone quality.
Right. And as specific as you can get. Specific is always better.
Yes.
But sometimes you don't have the information. So I'll go ahead to coding osteoarthritis. This is pretty similar to coding osteoarthritis in ICD-10. You still have to specify the type of arthritis, whether it's primary, secondary. You still have to specify if it's a localized type or form of osteoarthritis. You will need to specify the laterality and the joint, which joint is involved. And you can see by the code examples here how that information comes into play. Underdosing, and this is new for ICD-10, and this is a new concept. When you're documenting for underdosing, you want to hit two main points. Was this intentional? Was it unintentional? Is it outright noncompliance? And the second point is, what is the reason? Is it a financial hardship, or can the patient not accurately take their medication due to, an age-related debility? So I've got some code examples here to show in case you haven't taken a look at these codes yet, but they are important to note if this is going on with your patient.
So that is a great point, and I'm going to tell you guys this is absolutely new information for me, and I will start using this because the research, as you all know, in the FLS arena, the research shows that a lot of patients that are put on oral medications for their osteoporosis, they start it, but usually most of the patients will stop after 6 months, and that's why I try to have them follow back up. And so if you're starting a patient for the first time on one of those treatments, you really do want to have them come back in maybe at the 3 to 6 month mark, because you want to know if they're still taking their medication. And then at that point, is it a non-compliance issue, or maybe did they have maybe they had a problem with the tolerance of the medication and they just didn't call in? Maybe it's like Leslie's mentioning a financial hardship, or maybe they have developed a new problem with dysphagia or something like that, which would be an age-related debility. So these are things that you want to think about in terms of treatment. So this is an excellent code, especially to use for your follow-up FLS visits. When you've initiated therapy and you're having them follow up, that is also another reason for the medical necessity of that follow-up visit, because you want that patient to be compliant for reduction of future fractures. The other point is with certain medications that are a little more expensive, a lot of times our patients won't call us and tell us. They'll just stop it. So get them in for that follow-up, and then you can actually use this code now if there's an issue with compliance, or if the patient went on a trip and they went on a cruise and stopped taking their medicine for 3 months or whatever. That may have been an intentional reason, but that's a good reason to show that you're treating the patient, you're not negligent, and you're following up, but this was something that was done inadvertently to your treatment.
Right. And all these clinical documentation tips have been pulled directly from the CMS Clinical Concepts Guides. They have these on their ICD-10 website, and that's CMS. I've listed all the specialties here that they have clinical concept guides for, and they've got a lot of other great information. But I thought these clinical documentation tips would be helpful, especially for these types of visits. I've got a little link down there in case anybody needs that. And then fracture liaison service, and that's your specialty.
So here we go. Everybody that's on the call knows about this service. Debbie introduced it. We know about this process. But as we think about the change in what we're dealing with in terms of documentation and medical necessity, this is where it becomes really critical for us in terms of our pathway of communication with other providers. Whether we're in a large healthcare organization like we're here at Wake and we have this wonderful multi-million-dollar EHR system, or we're in a smaller rural area that may have, a non-integrated EHR, or maybe you're still on paper, in some way, fashion, or form. The whole point is we're all going to be held accountable for our documentation and our coding, so it doesn't matter whether it's electronically done or through paper or how we communicate. The main issue is that when we try to connect our FLS patients in our pathway, what we want to do is make sure not only are we helping ourselves with the right documentation and the right coding, but that as we release these patients back to other providers, maybe we're sending notes back to their primary care providers, we want them to understand what was the necessity behind this visit. So appropriate coding, appropriate matching of the patient's risk factors are very, very important as we go along. And you will find in your communication line with other providers that you, having been on just this call today, you're going to have a greater knowledge base about coding for the FLS service than people that are not necessarily on this call today. And so you may come in contact with people that say, how did you learn this? How did you learn how to code for this? So pass this information on, because, again, this is one of the biggest issues with the FLS service, where people saying we can't get paid for it, we don't know how to code for it, so forth and so on. So this has really given us the answers to all of those questions that we've had. This also is, if you look at the algorithm for the referral and the recruitment, this also is really great for that C-suite approach of, why is this important? Well, not only is it important because we're going to show reduction of future fractures, but now Medicare is actually paying us, reimbursing us to be able to take care of these patients in a timely fashion, get them on treatment by reducing the risk of future fractures, which helps reduce future health care costs. So it's all justifiable now as we look. And here at Wake, you've heard me say it over and over again, we say greater than 49 because we don't want to miss any of those patients. But you've got to think about all those patients that may come into your FLS program, and that may be patients that not necessarily have had fragility fractures, but maybe they've been referred to you or your providers because they are at high risk for a future fracture. And in that case, you're going to need those codes to say, this is an encounter for screening because they are at high risk, and how do I justify this visit? So everybody's familiar sort of with the care coordination model and kind of how that looks. But again, this is such valuable information that you can take forward and, of course, communicate with your colleagues as well. So, Leslie, I'll turn it back over to you.
All right. And with that, I've just got some osteoporosis screening tips or tips for these FLS visits. And these are questions that Ann actually gets a lot. Mm-hmm. So I've got here some clarification. If a provider of the same specialty is performing both follow-up care for a fracture, so this patient is in a global period, and they're doing an osteoporosis screening, you may want to consider two separate encounters, and that's for clarification in that documentation.
So for that part, if you are in an orthopedic practice and your orthopedic surgeon is following the patient post-fracture and sees the patient in the global period post-fracture, they're seeing them for the fracture care, then they can see the FLS provider on the same day and use a modifier 24. But if you are a PA or a nurse practitioner that is being utilized in the role of a post-surgical provider seeing post-op visits, and that patient comes in and you're having to address, their incision care, are they still taking their Lobinox, are they on aspirin now, you're doing those post-op x-rays, and you're looking at all of that. If that's what your main focus of that visit is supposed to be, then that's where I would say you would want to do the two separate encounters for clarification so that you actually get reimbursed for the osteoporosis screening and that it doesn't get lumped into your post-fracture visit.
Right, and the only piece with that is you have to make sure that your documentation is clear. This is an unrelated evaluation and management service if it's provided by the same practice, by providers in the same practice. So that 24 modifier is going to exclude the service from the global period. But again, Medicare is watching those 24 modifiers, so you've got to be sure that your documentation is clear, that it is a separate problem, a separate and unrelated evaluation and management service. And the last piece I've got here kind of goes along with that as well. If you've got two providers of separate specialties within one multi-specialty practice, so say a physiatrist and an orthopedic surgeon, those are separate specialties. The 24 modifier is not necessary while the patient's in global with one physician of one specialty if they see another physician, and that could apply to the FLS program as well, depending on the specialty of the providers that are treating the patient. And that's all that we have. Thank you so much for listening. We do have time for questions. We've tried to get to some throughout the presentation, but if anybody has anything, just let us know and we can start getting those answered.
Okay, so here we have a question. So if the ortho surgeon is seeing the patient for an osteoporotic fracture and the NP is seeing them for the osteoporosis treatment, can the NP use an osteoporosis code? Absolutely, because that's what you're seeing them for. So the orthopedic surgeon is seeing the patient post-fracture, and even though he used the ICD-10 pathological osteoporotic fracture code, that's the fracture code he's using. The nurse practitioner, if the nurse practitioner is seeing the patient for osteoporosis, you would use the osteoporosis code, and you would use any other supporting codes to show that that patient's at high risk. The only time that you might use that fracture code, as I mentioned before, at the osteoporosis visit would be if there was a non-union or a malunion documented somewhere, and you're just showing again that the patient has some complications related to probably related to their osteoporosis. So you're just identifying that, and maybe they're not healing real well, or maybe the patient has routine healing and they've missed a couple of visits and they haven't come in, and so you just found out they're healing well, and you're going to document that as part of their osteoporosis management. But you can use that fracture code if needed. But just for clarification, the surgeon would use the fracture code and the nurse practitioner would use the osteoporosis code.
Okay. And I did want to also mention, I see this another question about getting copies of these slides, and yes, we will make those available after the presentation.
And actually, this particular presentation will also be available, I believe, on YouTube, like the other prior webinars are as well, through Fracture Prevention Central, and Debbie can address that, at the end. I think, someone's asking about, can you please give an example of a 24 modifier code? So if a patient had a left intertrochanteric hip fracture, and they came in to see the orthopedic surgeon, and the orthopedic surgeon said, I'm going to refer you to our bone health specialist, our fracture liaison specialist, and then the patient's referred to you. You get the patient, and the patient is in the 90-day period of time post-surgery. If they are in that 90-day post-operative period, then you will, when you put your osteoporosis code in there, you will actually put a modifier 24 with that. And what that modifier says is that it's an unrelated evaluation and treatment. So Medicare at this time does not equate pathological osteoporotic fractures and fracture care with the true osteoporosis evaluation, so you would still use a modifier in that situation, and they also don't connect all fragility fractures with osteoporosis, so it's not considered a related evaluation. So that's why you can still use the modifier 24. So I hope that answers the question, but that would be the example. That the only time you would need the global, you would need the 24 modifier, is if you're in the same specialty. If you're in orthopedic practice, the patient is post-surgical, and the patient, and you're seeing the patient for osteoporosis, in that 90-day you would use a modifier 24. Say you're in a interventional radiology group or a physiatry group or a spinal group that does vertebroplasties. So vertebroplasties are 90 days. Kyphoplasty is a 10-day global. So if the patient had a kyphoplasty and they're out of their 10-day global, you wouldn't need to use a modifier. But anytime they're in a global period, post-procedure, post-fracture, that would be a modifier 24 use if you're in the same specialty. I think, can you address coding and getting payment for DEXA yearly if you're being treated for osteoporosis? Basically what happens in that, with that particular situation, and Leslie, you can correct me if there's any question about this, but in this particular situation, what you do is you order your bone density, and in your little comment section, you say, medication effectiveness monitoring, and then when they go to schedule the bone density, they will attach whatever information they need to show the medical necessity of that bone density to be done yearly. What I've started doing on my orders is, when I order that bone density and it's only been in a year because of treatment monitoring, I actually just put in the comment section, this is for medication monitoring and effectiveness medically necessary. And that documentation will usually get it cleared. The only trouble that I have is when patients call directly to get scheduled for the bone density. The very first thing that schedulers are told to ask is, have you had a bone density in the past 2 years? And if the patient says, yes, I had one last year, then they're going to say, it's not going to be covered. So you just want to make your patients aware that their bone density will be covered as medically necessary if you're doing treatment monitoring. So it will be covered yearly.
And that would just need to be also, obviously within your documentation.
Correct. Exactly. Let's see. We have a question about ordering labs for follow-up post-fracture. What code should be used if osteoporosis has not been determined? Okay, so you can use encounter for screening for that one, and you would use any other supportive diagnosis that would, like for instance, if a patient has reflux problems and they have a low vitamin D and you're concerned about celiac disorder, then you would use reflux and you would use vitamin D insufficiency, and you could that's how you could order that lab code. If you're worried about intact PTH, I'm going to tell you this right now, most of the labs, with the exception of TSH, most of the labs, if you use osteoporosis or you use the M code, the other disorders of bone density, most of the labs will be covered using those codes. They will attach and be associated with those codes. The only trouble that I've run into is the TSH, and that code I'm having to use the M, other disorders of bone density, and there's couple of other codes that I've had to use to get the TSH covered. Otherwise, the patient has to sign one of those ABN forms or whatever they're called, and I don't want to fool with that because, if we're trying to check it, then we need to check it. So, I hope that answers the question there when ordering labs post-fracture. Most of the time, the osteoporosis code will take care of it with the exception of the TSH. If you don't know if they have osteoporosis, then you would use any other supporting diagnosis to show the reason why. And if you think the patient has compromised bone quality, use that M code, compromised, bone density, what was that code? How does that code sound, Leslie? The M code that says compromised bone density and strength or something like that?
Other specified disorders of bone density and structure?
Perfect. You can use that if you're worried about bone quality, but you haven't definitively diagnosed osteoporosis with BMD. But keep in mind, if you have a patient that's had a fragility fracture, by definition, they have osteoporosis. So you can use osteoporosis code to get your labs ordered, even if you don't have the BMD or you don't have the bone density to tell you that they have osteoporosis. You can use the fragility fracture as your go-to for osteoporosis definition. Let me see. We're getting close to time here. I'm going to try to run through here. 24 modifier and fracture code or osteoporosis code. No, osteoporosis code would be the 24. Would be the one where you use the 24 modifier. So if you're using your osteoporosis code, then you use the 24 modifier attached if they're in the global period. What about annual lab work or frequency of follow-up in the clinic?
And I just wanted to mention that 24 modifier is going to be on your evaluation and management code. So that's going to be on your 99214, 99213, whatever level you're billing, not on any procedure codes.
Right. So your ICD-10 is different than your CPT. So if you are billing a level 4 visit for osteoporosis and you're using the ICD-10 code for osteoporosis, but it's a level 4 visit, face-to-face time 25 minutes or more, and they're in the global, that's when you would use that 24 modifier. There's a question here. There's another in-hospital question. Can the orthopedic surgeon bill under the fracture code, and can the NP or PA see the patient on the same day in hospital and start the workup? Okay, let me tell you my experience with that. First of all, number one, they're really pushing us away from doing quote-unquote unnecessary workups in the hospital. So now they're asking us really, Medicare is really pushing us to do more of the workup on the outpatient side. But right now, the way that it has been billed, and this is from my experience as rounding on some of these patients and doing osteoporosis evaluations, you cannot see the patient on the same day as surgery, and you can't see the patient as the same day of discharge. But if you go into the hospital and you see the patient for osteoporosis, and the surgeon has seen the patient for the fracture, you would use your CPT code would be an H&P subsequent visit. So I think it's a 99222 code. And then you would use your osteoporosis ICD-10 codes for that. So right now you can bill, but they are asking that we move away from that. But for clarification, just check with your billing and coding people to make sure. You can't bill a consultation code anymore, so you're just using an H&P subsequent H&P code in the hospital. There's another quick question here. What about annual lab work or frequency or follow-up in clinic for osteoporosis? I'm not sure if you're asking me what you order, or I'm not sure if you're asking me how often to see the patient. It depends on your treatment, first of all. So if you're treating a patient that you feel like you need to monitor a little closer, a lot of times I'll have the patient, when I first start treatment, I'll have them come back within the first 3 months just to monitor for compliance and make sure they're able to get it. There's no issue there. Lab work, I usually do their vitamin D levels and any kind of workup, obviously at the initial visit. I don't necessarily do a lot of lab work at the annual visit. Mainly, the main one that I would probably check at that time would be a vitamin D level, just to make sure that they're maintaining their vitamin D level. Okay, and one final question, because we got a minute. It would be, would fragility fractures only be considered hip, vertebral, wrist, and proximal humerus? Would other fractures be considered? So that's a great question. Right now, there was a position paper that was put out last January by a working group through the National Bone Health Alliance that stated that not only wrist, hip, and spine should be identified as fragility fractures, but also other patients that had low trauma-type fractures in any area, like the ankle, the humerus was added, pelvic insufficiency fractures. So look at the nature of the injury. If the patient had a low trauma injury, that position paper stated that we need to consider that they may have osteoporosis. That position paper can be made available on the Fracture Prevention Central website. So if you're not privy to that position paper, I'm sure Debbie can get that to you. I need to wrap it up, so I think we got to most of all the questions today. Thank you again so much. Thank you, Leslie, for all your hard work, and appreciate all the knowledge that you gave us today. Thank you again to everyone that's doing such a great job in standing tall for osteoporosis and reducing the risk of future fractures in our patients. Way to go, people. I'm going to turn it back over to Ms. Zeldo, and we'll wrap it up. Thank you so much. You guys have a great day. Debbie?
Great. Well, thank you so much, Ann, and thank you, Leslie. That was a fabulous webinar. I also wanted to thank all of you for joining us today and just reiterate what Ann had said, that the webinar will be available on the Fracture Prevention Central website as well as YouTube. And if there are any other items that were mentioned, we will post them as well. And do not hesitate to email me, dzaldo, at nbha.org if there's anything else that you need. I would ask if you could please complete the webinar evaluation form that will pop up once the webinar is done. Your feedback is very important to us. So thank you all again, and have a great day.
Thank you.